very good evening to one and all present here. I'm Priyanshi Sharma, host for today's webinar. Today we are presenting a webinar on HER2-positive metastatic breast cancer, newer approaches and access to care. For that, firstly, I would like to invite Dr. Ashok Vaid sir, Chairman of Medical Oncology and Hematology in Medanta, to give a welcome address. Thank you. Over to you, Vaid sir.
Thank you, Priyanshi. Good evening, everyone. And it's an honor and a pleasure to welcome everyone to this program on metastatic breast cancer, HER2 positive disease. And the theme is very appropriately put as newer approaches and access to care. All of us who are practicing in this part of the world always have the dilemma of choosing the best, choosing the right treatment always, but access is an issue always. My greetings to all those who have joined from the various international locations. And I learn there are many of our colleagues who have joined in from far and wide. A very warm welcome to everyone on the program. Also, my thanks to Biocon Biologics for giving me the opportunity to put this program together, and also to the faculty who have put up an excellent program here. Dr. Jyoti would be talking about the newer approaches in metastatic breast cancer. Dr. Neera, who represents Biocon, would be talking about the biosimilars, and very pertinent point about the availability of biosimilars, which has not only expanded the access, but also brought in the quality biosimilar to this country. And Dr. Sameer would be talking about the evolution in the landscape of breast surgery. Friends, we agree that metastatic breast cancer HER2 neu positive is a group of diseases in today's time. It could be a ER/PR negative HER2 positive, and it could be a triple positive or varying combinations of the same. There are still many issues in the choice of the first-line treatment, what's optimal, and of course, the continuation of pertuzumab in our part of the world, which is so very expensive, now becomes a critical issue. The next question always is, when these patients progress, and which they do over a period of time, how do we treat them in the second line setting? The advent of the newer drugs, drug antibody conjugates, that's a new landscape. We are actually realizing now treatments beyond the second line. And of course, the issue about brain metastasis continues to be a challenge in the clinic. And we know that patients, a good percentage of these patients would come back with brain metastasis, and they pose a challenge in terms of the therapeutic dilemma, whether it is oligometastatic or is it a part of a dissemination. All that needs to be diligently dissected out. And of course, as I said, the access remains an issue, and let's see how we deal with that over the next about an hour or so. With that sort of a context setting, I would hand over the mic back to the proceedings back to Priyanshi to invite the next speaker and take the proceedings on. Thanks once again, everyone on the program.
Thank you very much, Dr. Vaid sir. Now I would like to introduce my next speaker, who is Dr. Jyoti Wadhwa. She is the Director of Medical Oncology in Medanta, and she will speak on newer development in HER2-positive metastatic breast cancer. Thank you. Over to you, ma'am.
Please allow me to share my screen. Yeah, thank you. I hope my slides are visible now.
Yes, it is visible.
Okay. So hello, everyone, and thank you, Dr. Vaid, for making me a part of this academic program today. I shall be talking about newer developments in the management of HER2-positive metastatic breast cancer. A lot has happened over past decade in particular, and the treatment has advanced quite a lot for the patients with metastatic HER2-positive breast cancer. So we have these three types of treatments which are approved. One class of drugs is called HER2-targeted monoclonal antibodies. We all know that the journey of treatment of HER2-positive breast cancer started with the development of trastuzumab. However, we have come far in the journey, and we now have three targeted monoclonal antibodies, namely pertuzumab and margetuximab as well. We have HER2-targeted tyrosine kinase inhibitors, namely lapatinib, neratinib, and tucatinib now available for treatment of these patients, and a very interesting class of drugs called HER2-targeted antibody drug conjugates, which are very effective, very potent in terms of efficacy for the treatment of metastatic breast cancer patients. So we have, again, three molecules in this class also, namely TDM1, trastuzumab deruxtecan, and a newer one, trastuzumab deocarmazine. So besides trastuzumab, lapatinib, and TDM1, which we have been using for quite some time now, the other molecules listed here are all new. And I shall be talking about the trials which got them their recent approvals. We all are aware of the landmark Cleopatra trial, which established the standard first-line treatment for HER2-positive metastatic breast cancer with dual HER2 blockade with trastuzumab, pertuzumab, along with docetaxel as the new standard first-line treatment for these patients. This Cleopatra trial demonstrated a significant improvement in the median overall survival of these patients. The median OS was 57 months with the dual HER2 blockade with chemotherapy compared to single HER2 blockade with trastuzumab and docetaxel. It was only 40 months. So Cleopatra made this triple THP regime as the standard first-line regime for metastatic breast cancer patients who were HER2 positive. Subsequently, attempt to replace this with TDM1 failed, and TDM1 continues to be the second-line treatment choice and not the first-line treatment choice for HER2 positive metastatic breast cancer patients. Now, TDM1 got its place as the standard second-line treatment for metastatic breast cancer patients after they had progressed on prior HER2-targeted therapy based on these two important trials, namely the Emilia trial and the Theresa trial. The Emilia trial had compared TDM1 with the then standard lapatinib and capecitabine and found TDM1 to be superior in terms of improvement in the overall survival. Similarly, TDM1 was also found to do better when compared with the drug of physician's choice in another phase 3 study, the Theresa trial, and therefore TDM1 is the standard second-line treatment for this subset of patients. Now, as I said earlier, a lot of new molecules have been developed, and under these three categories, HER2 TKIs, we have two new molecules, namely neratinib and tucatinib. We have newer antibody drug conjugates, namely trastuzumab deruxtecan and trastuzumab deocarmazine, and we have a new re-engineered HER2 monoclonal antibody in margetuximab. So let's deal with these groups of drugs one by one. We also know that CNS disease or brain metastasis continue to be a significant problem in HER2-positive breast cancer patients. And almost 50% of patients with HER2-positive breast cancer do develop brain metastasis during the course of their illness. Capecitabine and lapatinib have the approval, and in the earlier pooled analysis, they were found to lead to a CNS response rate of 21% with median PFS of 4 months. Now, subsequently, the combination of neratinib and capecitabine got its approval for this setting when it was found to lead to a CNS overall response rate of 33%. So the neratinib capecitabine combination was compared with lapatinib capecitabine combination in the NALA trial. in those patients who had failed 2 or more prior lines of HER2-targeted agents. In this study, asymptomatic stable brain metastasis patients were allowed. So capecitabine in the standard dose and neratinib in the dose of 240 milligrams a day every day was used. And this was compared with the standard dose of lapatinib with capecitabine. This trial had 2 co-primary endpoints, namely overall and the progression-free survival. Now, the NALA trial demonstrated that the combination of neratinib and capecitabine was better in terms of improvements in the progression-free survival. The overall survival, however, seemed similar. The time to intervention for CNS metastasis was, however, prolonged in the neratinib arm, and the cumulative CNS incidence was greater in the capecitabine lapatinib arm to the tune of 29% versus 22% in the neratinib arm. So it seemed to perform better when compared with the then standard capecitabine lapatinib. So neratinib with capecitabine had better CNS efficacy. The side effects were as expected. However, diarrhea, nausea, and anorexia were more in the neratinib arm compared to the lapatinib arm. Now, the other newer TKI is tucatinib. This has less of EGFR-associated toxicity. It is more selective HER2 TKI and therefore is said to be more potent. Also, this has greater CNS penetration, and in fact, it has been found to have greater efficacy for treatment of patients who have brain metastasis. The HER2 CLIMB is the phase 2 trial, which had compared the combination of tucatinib with trastuzumab and capecitabine and compared this with placebo and trastuzumab with capecitabine. The patients in this study could have had brain metastasis. So the progression-free survival was the primary endpoint. And what did HER2 CLIMB trial show? It showed that at 1 year, the progression-free survival rates were 33% in the tucatinib arm versus only 12% in the placebo with trastuzumab and capecitabine arm. So clear superiority of tucatinib-based combination in this study. All these subgroups in HER2 CLIMB study benefited from the addition of tucatinib, irrespective of age, ethnicity, hormone receptor status, presence or absence of brain mets, and different geographical locations. They all did better with tucatinib versus the other placebo arm. The overall survival also seemed to be better. The hazard ratio was 0.66, so there was 34% reduction in the risk of death with the use of tucatinib. Again, on the subgroup analysis, all the subsets, as I mentioned earlier, seem to do better with tucatinib compared to the placebo arm. The progression-free survival in patients with brain metastasis. So if you see here, again, note here the 1-year PFS in those with brain metastasis was 25% in the tucatinib arm, and it was 0 in the placebo arm. So there was nobody in the placebo arm who was progression-free if the patient had brain metastasis at the baseline. So a hazard ratio of 0.48 there. So meaning thereby 52% reduction in the risk of disease progression. So very marked superior efficacy in patients with brain metastasis. Herein, I list 2 other HER2 TKIs, namely pyrotinib and poziotinib, which are under active research. And in fact, Phoenix trial has demonstrated improvements not only in the overall response rates, but also in the progression-free survival with pyrotinib when added to capecitabine. Coming to the other class of agents called HER2-targeted antibody drug conjugates. So a very peculiar class of drugs. As the name suggests, there is an antibody which targets the breast cancer tumor antigen. There is a potent cytotoxic payload, and there is a stable linker which releases the payload only in the target cell. So very interesting concept. And TDM1 was the first HER2-targeted ADC that got its approval. Herein, we know that trastuzumab is the antibody. The cytotoxic agent is DM1, and there is a thioether linker, which is quite stable. The other newer antibody drug conjugate is trastuzumab deruxtecan. Herein, the antibody is a humanized anti-HER2 IgG1 monoclonal antibody, which is quite similar to trastuzumab. However, it's not exactly the same. This ADC is characterized by very high drug antibody ratio of 8 and therefore is highly potent. Destiny Breast 01 or 01 is the trial, which was in fact a two-part phase 2 study. The first part involved the dose-finding component of the study, and it demonstrated that trastuzumab deruxtecan in the dose of 5.4 milligram per kg every 3 weeks was better, and that is the dose which was carried forward. The other part of this trial was the efficacy or study of the overall response rates. So if you notice here, the patients in this study, Destiny Breast 01, had received median prior lines of treatment to the tune of 6. And look at the range. They might have had received 2 to 27 prior lines of treatment. 91% of patients had visceral disease. And what do we find? The overall response rates of 61%, disease control rate of 97%, and median duration response of 14.8 months, which is quite impressive for such late line of treatment for patients with HER2 positive metastatic breast cancer. So very effective molecule there. This also demonstrated a median progression-free survival of 16.4 months, and the overall survival in this study was not yet reached at median follow-up of 11 months. Interesting side effect, interstitial lung disease was noted. Any grade ILD to the tune of 13.6%, and grade 5 also in 4 patients was documented in this trial. So one has to keep that in mind and exclude patients with known interstitial lung disease. And the patients also need to be monitored for interstitial lung disease and pneumonitis while on treatment with trastuzumab deruxtecan. So this molecule got its approval in December of 2019 for patients who could have received or failed 2 or more previous HER2 targeted therapies for metastatic disease. Subsequently, we have Destiny Breast 03, a phase 3 study, which compared trastuzumab deruxtecan with TDM1, both in the standard doses, for patients with metastatic HER2-positive breast cancer who had previously been treated with trastuzumab and a taxane in the advanced setting. So primary endpoint of this trial was progression-free survival. Both the groups were well matched for baseline characteristics and also for the types of prior therapies received. The progression-free survival here, note, it's not yet reached with trastuzumab deruxtecan, and it was 6.8 months with TDM1, hazard ratio an impressive 0.28. PFS by investigator assessment also markedly superior here. The median PFS was 25 months in trastuzumab deruxtecan versus only 7 months with TDM1. The overall survival is not yet reached. However, the data is early, but the hazard ratio seems to favor trastuzumab deruxtecan for OS as well. For PFS, the hazard ratio was 0.26. So a superior molecule there when compared to TDM1. What about the response rates? The overall response rate reported with this molecule was 79% versus 34% with TDM1. Complete remission seen in 16% versus 8% with TDM1. So overall disease control rate with trastuzumab deruxtecan of 96.6%. So very effective, very efficacious molecule. The side effects, as were expected, interstitial lung disease or pneumonitis documented in 8% of patients. And we are all aware of thrombocytopenia being a significant side effect with TDM1. So patients do need to be monitored for that. So this Destiny Breast 03 trial concluded that trastuzumab deruxtecan is a superior molecule compared to TDM1, and in fact is the preferred second-line option for HER2-positive metastatic breast cancer in all the current standard international guidelines. Destiny Breast 04 is currently studying, has studied trastuzumab deruxtecan in comparison to chemo in a very specific subset of patients called HER2-low breast cancer, which is very peculiar subset, wherein on IHC, it's reported as a 1+ or 2+. However, the FISH test is negative. So for this HER2-low breast cancer, trastuzumab deruxtecan has been found to do better when compared with chemotherapy. Coming to the third antibody drug conjugate, trastuzumab deocarmazine. So this is another interesting molecule wherein the active toxin DUBA alkylates DNA, and that's how it kills the cancer cells. The antibody remains trastuzumab, and there is a linker involved, which will release the cytotoxic agent in the target cell. This has been found to lead to response rates to the tune of 33% in patients with metastatic breast cancer. And TULIP study is the phase 3 trial, which is studying this and comparing this with the treatment of physician's choice, with PFS being the primary endpoint. Now, HER2-targeted antibodies, we are aware of trastuzumab and pertuzumab. There is a new entrant in this class of drugs called margetuximab. This novel HER2-targeted monoclonal antibody has altered Fc receptor affinity. This results in increased CD16A affinity, which is responsible for enhancement of innate immunity, and therefore more potent ADCC is attained. With the resultant decreased CD32B affinity, however, there is enhanced adaptive immunity and therefore increase in immune activation. So it works by both ways, in dual ways. SOPHIA trial is the phase 3 trial, which compared margetuximab with trastuzumab in patients who had failed 2 or more prior treatments for metastatic disease. The progression-free survival with margetuximab with chemo was reported to be 5.6 months versus 4.2 months with trastuzumab and chemo. And both investigate the hazard ratio was 0.7. So improvement in PFS noted there. The first and the second interim overall survival has been reported. However, it does not seem to differ between the two arms. However, in a given particular subtype, this type, which is written here, patients who carry CD16A carriers of this seem to do better with margetuximab when compared with trastuzumab, with a delta of 4.3 months. So this is how the current NCCN guidelines look for the recommendations for treatment of patients with HER2-positive metastatic breast cancer. The pertuzumab, trastuzumab, docetaxel, or paclitaxel remain the standard first-line treatment as demonstrated by Cleopatra trial. The second line, which earlier used to be TDM1, has now been replaced based on the Destiny Breast 03 trial to trastuzumab deruxtecan as the preferred second-line regime. The third line and beyond, we have lots and lots of options available. However, the exact or optimal sequencing is not yet known. One could use and choose based on presence or absence of CNS metastasis and comorbidities. So herein, find the place, the molecules like tucatinib or other chemotherapeutic agents with trastuzumab, or capecitabine with lapatinib, especially for our patient population, continues to find its place in third line and beyond. So this is how in our practice we are still choosing, because we don't have trastuzumab deruxtecan yet available for use in India. So taxane with trastuzumab and pertuzumab continue to be our preferred first line. TDM1 continues to remain as our usual second line in absence of availability of trastuzumab deruxtecan, and subsequently third, fourth, fifth line could be chosen based on the way I just mentioned. So thank you once again, and I would end my talk here. Back to the organizers. Thank you.
Thank you so much, Dr. Jyoti Wadhwa, ma'am. Now, I would like to invite my next speaker, who is Dr. Neera Gupta. She is the Senior Director of Medical Affairs in Biocon Limited in Bangalore. Her topic is Quality Biosimilar Trastuzumab, Improving Access to Care in HER2-positive breast cancer. Thank you. Over to you, ma'am.
Thank you so much, Priyanshi. Allow me to share my screen. Is it visible?
Yes, just put it full screen, ma'am.
Yeah.
Yes, visible.
Great. So very good evening and good morning across the world. We have the participants today. It's a great privilege to be part of this esteemed speakers and Dr. Vatsar as the program chairperson for this meeting. The task I have in front of me is quality biosimilar trastuzumab, improving access to care in HER2-positive breast cancer. Dr. Jyoti has made my job a little easier, and I will start where she left. So I'll be covering my talk in what is the need of biosimilars, challenges in development of biosimilars, expectations from an original biosimilar, evidences behind a quality biosimilar, and I'll conclude my talk. So as Dr. Jyoti said, that trastuzumab still remains the first line of treatment and the treatment of choice for HER2 disease. And if we see this publication that talks about that the global need for a trastuzumab biosimilar for patients with HER2-positive breast cancer, and it says that in case of EBC, more than 60% of the patients, they are not able to receive trastuzumab. And in case of MBC, up to 50% of the patients, they are not yet able to receive trastuzumab. There's some more data that talks about financial toxicities of cancer in low and middle income countries, perspectives from Southeast Asia. And that talks about countries like Philippines, wherein the insurances are not there. Not much coverage is there. There are more than 60% of the patients, they are not able to receive trastuzumab. While where the insurance coverage is there, that around 15% of the patients still not able to receive the trastuzumab. And if we look on the right side, the financial toxicity in cancer care in India, systemic review, it talks about the financial toxicities. What are the risk factors for financial toxicities? Of course, we know that low income, private healthcare facilities, rural household, younger age, and so on. But what are the consequences of this financial toxicities when patients are not able to complete their treatment? It leads to poor quality of life, delay in treatment therapy, lack of follow-up, and non-adherence to treatment. This is the NCCN guidelines wherein FDA-approved biosimilar. It says that FDA-approved biosimilar is the appropriate substitute for trastuzumab. And we at Biocon, we were the first one to get a biosimilar trastuzumab approved by US FDA, and it is mentioned in NCCN guideline as a substitute to the reference trastuzumab. So whether we talk about the neoadjuvant adjuvant treatment in EBC, or we talk about the metastatic breast cancer, it is a treatment of choice. So when we are talking about biosimilars and the market access, there are two questions: the comparability and the cost. So how does a biosimilar that compares with the reference trastuzumab, and what are the cost comparisons of it? But before we go there, there are regulatory pathways which are well-defined biosimilar guidelines. According to that, any biosimilar that needs to go through during the development. And if we see that the regulatory environment is much more stringent in the regulated markets like US, EU, and Japan, while the emerging markets are yet to reach there. If we see the regulatory landscape of biosimilars in the US, we'll see that it was under BPCA Act in 2010. 2012, where the first FDA guidance on biosimilar was developed in US, and 2015, where the first biosimilar in form of filgrastim that got approval in US. And since then, there is rapid progression in terms of approvals and usage of the biosimilars. Let's look at the key challenges in the production of biosimilars. So there are a lot of challenges. It's not that easy to bring any quality biosimilar into the market because it has to go through the same steps of development. It takes almost 8 to 10 years of development to get a quality biosimilar into the market. So if we look at a couple of challenges like clone selection, why it is important? Because it is important for matching critical attributes and difficulty in fingerprint mapping. The biosimilar has to exactly fingerprint the innovator or the reference trastuzumab, and little bit variance in case of clone selection that can lead to a different product altogether. Let's look at the post-translational modifications. They are very glycosylation patterns. They are very, very important, and little bit of difference in terms of glycosylation patterns. It leads to more of immunogenic profile and immunogenicity that is, that in terms of biologics, when we talk about immunogenicity is really a concern. Talking about impurities and aggregations, they are another factors. If the production is not as per the norms, there will be a lot of aggregates and impurities, the viral particles that will be cause of more of adverse events and little lesser the efficacy part of it. And scalability, the batch to batch consistency has to be adopted even in the biosimilars. It has to match, each batch is similar in terms of critical quality attributes when we see the final product. So global development of quality biosimilar is highly complex because manufacturing a biosimilar is extremely complex that requires extensive knowledge and expertise, comprehensive infrastructure, expertise to navigate through the regulatory maze, the long incubation period, and success is still not guaranteed. What are the expectations from an ideal or original biosimilars? This is from the Journal of NCCN, little old paper, but still holds true because it talks about the majority of the physicians and the participants in this survey. They talked about studies that show chemical, physical similarities between innovator and biosimilars is the important criteria before they choose any biosimilar. Similarly, studies that show pharmacokinetics, absorption, distribution, metabolism, and elimination similarities between innovators and biosimilars is must to see before any biosimilar is selected. What about the clinical endpoint? Whether the valid clinical endpoints have been tested in the pivotal trials or not is another criteria. 74% of the people, they said that they look for it. Inclusion in the guideline and compendium of a biosimilar, 64% of the participants, they said that they look up to whether the molecule is present in the guideline or compendium or not. So we saw that a quality biosimilar that goes through the stringent regulatory pathways with all data points and evidence generations, once it is included, that gives the confidence to physicians and oncologists to use that biosimilar. So is quality of pharmaceuticals a problem? Yes, quality is always a concern. Today, in today's world, we see more than 15 biosimilars of trastuzumab. But how do we ensure that this is the right quality biosimilar for our patients that gives confidence to oncologists to use it? But this data is from WHO, not really for biologics, but it talks about the quality is a concern where it can be, the possibilities can be incorrect ingredient, incorrect amount, there are errors, no active ingredient present. So there are a lot of issues in terms of qualities. And when WHO has posted that are all medicines safe, effective, and meet the quality criteria? No, they are not. Some are safe, but not effective, or necessarily meet the quality criteria. Some may be effective, meet quality criteria, but not safe. Some meet quality criteria, but not necessarily safe and have the efficacy. So we need to choose that what is that which has been proven through evidence, and that builds the confidence. Yes, it is safe, it is efficacious, and it has the quality batch to batch. So cost is not the only consideration. What it says is if the drug of choice is based solely on direct cost, there is an inevitable risk that some of the products will not be bioequivalent, and the result will be treatment failure or toxicity or increase in direct costs. So it's not about the cost, it's about the quality that is very, very important. When we talk about biosimilars, fingerprinting like similarity, this is how it looks like, that various tests, or when we call it as critical quality attributes, like form, identity, structure, size, these are some of them to name it now, concentration, activity, purity, surface charges. Each parameter or each attribute is tested through multiple tests, and each test has to result the same outcome. Then we say that it is the orthogonal way of assessment, or it is the fingerprint-like similarity. Using the sensitive cell-based assay for functional characterization of MABs. So when we see the regulatory pyramids of the two, the innovator biologic and the biosimilar, the pyramid is inverted for biosimilar development, wherein the analytical and functional characterization that makes the foundation the bigger piece of development. This only at the first step tells whether any biosimilar can go to the next level of development or not. And for each parameter of these assessments, there are multiple tests. Like for functional characterization, if we talk about, we look at antigen binding, programmed cell death parameter, the CDC, ADCCs, MAB half-life, and they're tested by different methods to look at the outcome. So FDA clearly recommends that residual uncertainty should be avoided completely. There should not be any residual uncertainty when we develop any biosimilar. So there are a lot of preclinical tests that is mandatorily asked for any biosimilar development, like single dose comparative PK study in cynomolgus monkeys, very specific because they share the same genetic milieu as that of more 95% or so as that of human beings. So this has to be tested in cynomolgus monkeys. The 4 weeks repeat dose toxicity and toxicokinetics in cynomolgus monkeys. The in vitro test, because trastuzumab has the potential of cardiotoxicity. So whether the in vitro tests or cell-based assays have been tested or not, that all is asked by FDA. So we have a lot of biosimilars, but still there are concerns from physician side about adopting the biosimilars. And these concerns are narrated as insufficient safety database, low quality of biosimilars in terms of physicochemical and functional characterization, the clinical performance, the no comparative studies, whether the drugs have been tested in sensitive test models and the expected sensitive endpoints or not, whether they have been tested for equivalence or non-inferiority, what is the volume of evidence and data complexities in terms of CMC assays. So bringing a quality biosimilar, it's a huge task, and it is as good as bringing an innovator, but definitely it increases affordability and access to care in terms of where we are talking about financial toxicities for cancer patients across the world. So role of biosimilar trastuzumab in management of HER2-positive metastatic breast cancer, Dr. Jyoti had already taken us through that, but this is the development of our biosimilar trastuzumab. We started its development from 2007, and then in 2013, it was commercialized in India, and we got approval subsequently in US, and established equivalence of what all tests we did for establishing the physicochemical characterization. Over 35 state-of-art methods were employed to demonstrate the high similarity, and these are the various tests in terms of the first pillar of development that were tested. Equivalence was tested in terms of HER2 binding, and we see the difference that was very, very minimal, and both innovator and the biosimilar trastuzumab was found to be safe. Looking at bioequivalence, you see the overlapped curves of our biosimilar trastuzumab vis-a-vis US and EU Herceptin. They all fared same in terms of area under the curve and Cmax concentrations. Heritage study, most of us, we have talked about it, but we know it that it's the largest pivotal trial of any biosimilar trastuzumab across the world, and it has the longest follow-up in terms of patients' data. So in this trial, 17 countries, they participated. 11 patients, 2.4% were from Africa. Asia Pacific, 142 patients, where India was also part of, that was 31%. Latin America, 5 patients, 1.1%. And Eastern Europe, 300 patients, 65% of the patients were contributed. What was the study design for Heritage? It was a double-blind international study. The patients were randomized into the 2 arms. Patients received the loading dose of 8 milligrams per kg, followed by maintenance dose. They either received the docetaxel 75 milligrams per meter square every 3 weeks, or they received paclitaxel 80 milligrams per meter square weekly regimen 30 minutes after the trastuzumab infusion. And those who showed the stable disease, they were continued on the maintenance dose. This was the subject disposition. The ITT intent to treat population was 458, and 230 patients were in Biocon trastuzumab arm, while 228 patients were in reference trastuzumab arm. The primary endpoint was at 24 weeks, the ORR, overall response rate, and secondary endpoints included time to tumor progression, progression-free survival, overall survival, and duration of response. The part 2 of the study included at 48 weeks, the primary endpoint assessment of safety, tolerability, and immunogenicity, and secondary endpoint included PFS, OS, the duration of response, OS at 48 weeks, and OS at 36 months. If we see the baseline characteristics of the patients in the 2 arms, they were equally distributed in both the arms. Patients less than 50 years, patients more than 50 years, disease-free interval of these patients less than 2 years. If you see, they were almost equally distributed in both the arms, and majority of the patients, they received the docetaxel 83% and 84% respectively, and lesser number of the patients that received the paclitaxel. If we look at metastatic sites, most of the patients, around 60% of the patients in both the arms, they had metastatic sites 1 or 2, and rest, minimal number of the patients, they had metastasis in more than 2 sites involved. The presence of visceral metastasis, 75% close to, and 81% in case of reference, they had the visceral metastasis. Most of the patients were in ECOG performance status 0 to 1. CNS metastasis was not present. It was no for all the patients. The primary endpoint of overall response rate, if we look at our trastuzumab, it was 69.6% compared to 64% in case of reference trastuzumab arm. If we see the ratio, it was 1, which says that there was no difference in the 2 arms. If we look at 48 weeks data, the PFS and OS curves, the median PFS was 11.1 months. In both the arms, it was exactly same. And the overall survival at 48 weeks, 89% of the patients were surviving in case of Biocon's trastuzumab arm, vis-a-vis 85% in case of reference trastuzumab arm. If we look at safety and the adverse events that occurred in more than 10% of the patients from baseline to week 48, they were similar almost in both the arms. There was no difference in terms of adverse event across blood, lymphatic system, GI, nervous system, general disorders, or musculoskeletal system. Looking at LVF is very, very important when we are talking about trastuzumab. And through the cycles that we look at, there was no difference in terms of LVF function, either it was reference or the trastuzumab. If we look at immunogenicity profile, that was also exactly same. The reference trastuzumab had patients 2.8% that shows the anti-drug antibodies, while CanMab are trastuzumab that showed 2.4% patients anti-drug antibodies. This is the long-term overall survival data that I was talking about that was presented in ASCO. The 3-year follow-up, if we look at the median OS was 35 months in Biocon's trastuzumab arm compared to 30 months in reference trastuzumab arm. So this trastuzumab, biosimilar trastuzumab from Biocon is backed up with robust data, thorough evaluation, and evidence across the development stages, right from the preclinical, the analytical characterization, pharmacokinetics, the pivotal data, and the long-term follow-up data. But it doesn't stop there. If you look at further real-world evidences, there are a lot of real-world evidences that have come up with our trastuzumab. This is the first data that talks about the cost efficiency of our biosimilar trastuzumab vis-a-vis reference IV trastuzumab and subcutaneous trastuzumab. It was found to be lost a lot of cost savings with our trastuzumab versus innovator IV and the subcutaneous. This is the data from Morocco, wherein in real-world setting, they switched the patients from the innovator to the biosimilar trastuzumab, and they didn't find any difference in terms of safety or efficacy after switching from innovator to our trastuzumab. This data is from India by Dr. Shona Nag, and this data talks about an early breast cancer and locally advanced breast cancer, wherein the EFS rates were similar. The 3-year EFS rates were similar, 57% in trastuzumab reference arm vis-a-vis Biocon's trastuzumab arm. This is the first data in terms of PAT-CR evaluation for our trastuzumab from CMC, and what it talks about when it was given in neoadjuvant setting. It led to the similar PCR rates, 41.7% with our trastuzumab versus the 37.6% with the reference. So we have a lot of biosimilar, but it's a judgment that we need to take a call that which is the right biosimilar, which is backed up with the evidence, and why this is the quality biosimilar to be offered to our patient for the best outcomes. When I'm talking about the improved access to care, the trends of biosimilar uptake is really changed now. And this is the data 2021, and that talks about in January 2020, the trastuzumab biosimilar uptake was 8%, and it rose to, by December, it rose to 74%. The uptake of biosimilar trastuzumab. Of course, that was the COVID time, but however, it is on a steep curve, and biosimilars are being adopted by physicians so that the patient can receive the treatment. They are not deprived of the anti-HER2 treatment. So to conclude my talk, an original biosimilar or the ideal biosimilar trastuzumab is proven equivalent to reference trastuzumab in all parameters. At 48 weeks, there was no significant difference in terms of PFS, OS, safety, immunogenicity, PK parameters. They all were comparable. 36 months follow-up data shown long-term safety data in terms of median overall survival comparable with the reference trastuzumab. Heritage trial is one of the first global multicenter trial with any biosimilar in oncology to demonstrate similar efficacy, safety, and immunogenicity against the reference product. Thank you for your patient listening. I would be happy to take the questions after the all sessions. We have next session lined up, and post that we'll open up for question and answers. Thank you so much. Over to organizers.
Thank you so much, Dr. Neera ma'am. Now, I would like to invite our next speaker, Dr. Sameer Gupta. He is the Associate Professor of Medical Department, Surgical Oncology, King George Medical University from Lucknow. and his topic is Evolving Landscape of Breast Cancer Surgery. Thank you, and over to you, sir.
Hi, am I audible?
Yes, sir, you are audible.
So, if you allow me, I can just share my slide.
Yes, you can share the slide, sir.
Okay. Is my screen visible?
First, you need to rotate your screen as in landscape mode. It is in a portrait
Okay.
mode.
So, yeah,
Just a second, sir.
is it
Yeah.
visible now?
Yeah, very well.
Yes,
Yeah,
sir.
okay.
Yes.
So, thank you, organizers, for giving me this opportunity. Just a snapshot of the journey of how breast cancer surgery has evolved from radical to sublime. So the origin can be traced back to say 2000, 3000 to 2500 BC, earliest reported case of breast cancer, and with the statement that there is no treatment. Then Hippocrates' time also 460 to 370 BC, there was no definite treatment for breast cancer. And then came the pessimist era lasting for about 1500 years, where the generally accepted dictum was that it is futile to treat breast cancer. And then the optimistic era started from 1750 onwards, when the French surgeon advanced this theory that cancer is spread by a contiguous route, and therefore a wide oblong operation can cure cancer. But surgeries during those times, because of no good cauteries or other antibiotics available, pre-antibiotic era, mortality rate of 20% even for a breast cancer surgery. So the major ray of hope or the major advancement in the surgical treatment for breast cancer came in with Halsted, who described his report of radical mastectomy for breast cancer in 1907. So he propounded the theory that breast cancer spreads by contiguous spread. So we can do a radical mastectomy whereby we remove the breast and along with the underlying pectoralis muscles and the regional lymph nodes. So this is more of a breast amputation than a breast surgery, but for those times it was quite a remarkable improvement in recurrence rate that it showed, and recurrence rates fall down from 6% from the prevailing rate of more than 50% at that time. And then we had the realist era, wherein patients started questioning the need for such a radical surgery for breast cancer. And therein came modified radical mastectomy, which is still a backbone of surgery in our part of the country, wherein we have locally advanced breast cancers quite a lot. So herein we used to do a modified surgery whereby we could preserve the underlying pectoralis muscles as well as the nerve to serratus and latissimus dorsi as well. So most common modification of MRM that we use is the Auchinclosis modification, whereby pectoralis minor muscle is retracted and not divided. And then came in the 1980s, and with that came in the breast conserving surgery. As our previous speakers have alluded to, more and more adjuvant, neoadjuvant chemotherapies are coming in. And with more effective neoadjuvant and adjuvant chemotherapy, it was possible to sufficiently downstage the disease and do a breast conserving surgery there. So, breast conserving surgery, whereby you remove a breast lump combined with axillary lymph node dissection. Sorry, I think I missed it. Sorry for the interruption, actually. Yeah, so breast conserving surgery, whereby we do a lump excision, axillary dissection, and combined it with a mandatory adjuvant radiotherapy. This is one of our case, pre-chemotherapy. We can see a breast lump in the right lower quadrant. Post 4 cycles, near complete resolution, just a clip marking the location of the lump can be seen. And following a breast conserving surgery, this is the scar post breast conserving surgery. And patient still doing well 5 years down the line. So factors favoring breast conserving surgery would be small tumors, less than 5 centimeter, young age, fresh breast to tumor ratio, patient being compliant for radiotherapy as well as for regular follow-up. Contraindications being a multicentric disease or a diffuse microcalcifications, pregnancy which precludes giving adjuvant radiotherapy, or persistent positive margins at the conservation surgery. Various studies now have been there which have shown equivalence of breast conserving surgery to MRM with near similar OS and DFS. Similarly, local recurrence rates of BCS, that is lumpectomy and radiotherapy, is almost at par with mastectomy. The next evolution in breast cancer surgery came in the form of sentinel lymph node biopsy, whereby a radioactive tracer is injected in clinically node negative patients and you remove only the nodes which take up the tracer uptake, and you don't have to do a complete axillary dissection. Thereby, the incidence of lymphedema significantly is reduced. So sentinel lymph node biopsy technique shown here, whereby you inject the dye around the tumor and the radio tracer probe picks up the dye in the axilla. You give a small incision in the axilla, just remove those blue or the hot nodes. And if those nodes are negative, axillary dissection can be precluded. So dye can be injected either peritumorally or subareolar. Slightly massage at the breast and then a small incision in the axilla. Identify the blue node. If you're using a dye or a radio tracer, then you have a probe to pick up that node and send it for frozen. If those nodes are negative, axillary dissection can be avoided. And quite a few of trials have shown that if sentinel lymph node is negative, you can safely avoid doing the axillary dissection, especially in a clinically node negative axilla. And then came in the advent of plastic surgery techniques transposed into breast conserving surgery to improve the aesthetic results. And therein came the era of oncoplastic breast surgery from 2000 onwards, wherein two techniques of volume displacement, wherein just local mobilization of fat is there to fill up the defect following surgical excision, or replacement procedures whereby we use tissue flaps to replace the excised breast volume. This is one of our case where in oncoplastic technique we did a round block technique and removed the tumor which is close to the areolar complex, and the reconstruction post excision by volume displacement technique was quite good cosmetically. And oncoplasty using volume replacement is by the means of flap, like an LD flap being shown here. So these are the various techniques that a specialist breast surgeon in a specialized oncology setup practice to maximize the cosmetic outcomes. So here in our department, for 300 patients over 2 years, most of them are locally advanced breast cancers. Therefore, the most common surgery that we do is MRM, with breast conserving surgery comprising less than 10%. So what explains the low rate of breast conserving surgery in our setup? Most of the patients come to us quite an advanced disease. Quite a significant percentage present post-lumpectomy with oddly placed scars, unwilling patients, lack of awareness, and problem of diligent follow-up. Fear of radiotherapy contributes no less. So these are some patients present to us, and therefore breast conserving surgery is obviously not an option in these patients. These are the patients with variously oddly placed scars when they come to us, making breast conserving surgery really difficult. So the numerous myths and ignorance that prevail results in unrealistic fear of the disease, especially cancer, and therefore it's difficult to explain breast conserving surgery to these patients. So as you can see, breast surgery has evolved from a radical mastectomy to a modified surgery to now an oncoplastic or a breast conserving surgery. Thank you. Over to the organizers.
Thank you so much, Dr. Sameer. Now, I would like to call.
Priyanshi will be having a Q&A session, so you can
Okay.
proceed, please.
Yeah.
So, Priyanshi, we are done with the presentations.
Okay.
And thank you so much for that wonderful moderation.
Thank you, sir.
Now, Neerav, are there any questions in the chat box?
Sir, I have just posted one question in the question answer box. You can see that.
Okay. Let me look at that. Question is that is there any surgical option for loco-regional recurrence of HER2 breast cancer? So, Dr. Sameer, if you could take that question, that loco-regional recurrence in an HER2
Sure, sir.
positive.
So, after a proper metastatic workup and eliciting the initial treatment received by the patient, whether it was a modified MRM done or a breast conserving surgery done, we need to do a metastatic workup, a PET scan to rule out any metastatic disease. And once there is no evidence of any metastatic disease and the disease is primarily resectable, we can definitely go ahead and do surgery for a local recurrence.
So it's like any local recurrence after a primary treatment. So you deal it on the merit of it. Operable, operate.
Yes.
Very well. And then Dr. Jyoti, taking on from the question which was answered just now, we always say that local recurrence is a harbinger of a systemic relapse. Would this call for starting a second line therapy or a subsequent line of therapy for an individual like this, for a woman presenting in such a situation?
Yes, so usually, we assess the tumor burden and the sites as mentioned by Dr. Sameer, rightly so. And if it's really localized, only then we offer a local treatment for that. If we have dealt with it in a complete and satisfactory manner, one has the option to continue the prior ongoing systemic therapy, especially if it was working at all the other sites. So if that local site was the only point of recurrence or progression, then it's good to continue the same systemic treatment after offering the local treatment. However, if the progression is beyond that also, then we should change the systemic treatment.
Thank you so much. I hope Dr. Frida Ong, that answers your question. And there is another question in the question box by Dr. Raghavendra Rajeshwarkar. What is the second line therapy when only trastuzumab is in the first line? Dr. Jyoti, if you could continue with that.
So as I mentioned, one has the option of using TDM1. It's a very efficacious drug, very effective if the trastuzumab-based combination has failed in the first-line treatment. We, in fact, have the biosimilar option also available for use in India. So that would be the preferred and better option. However, if there are some concerns, there are other options also, such as lapatinib-based combination, which is an oral option. One also needs to keep in mind the time to progression, how well the patient has done on trastuzumab and how much is the patient failing, because that also could continue to be an option. Trastuzumab-based combination could still be useful in the subsequent line.
Ma'am, just a question. If patient has just received trastuzumab initially, then trastuzumab, pertuzumab can be an option for second line, or you have to go straight to TDM1?
Yeah, that could also be an option, but it hasn't really been used. Why? If the patient could afford and was eligible to get a pertuzumab-based combination, I would rather offer that as the first-line treatment.
Exactly.
Wherein it works the best way, instead of adding that in the second-line treatment.
Second line, then TDM1 is a better option rather than a
Yes.
combination.
Yes.
Yes, agreed.
So there is another question by Dr. Raghavendra. When HR positive, HER2 positive, so B, which side is best? I couldn't understand. Dr. Raghavendra, if I could request you to retype your question, it'll help us understand the question better, and probably you'll get a better answer to that. So moving on, Dr. Ashutosh Sahiwala, how about management of local recurrence with oligometastatic disease? Should we go with curative intent using second line chemotherapy followed by local treatment? So it's reversing the sequence now. That should it be systemic first, followed by the local treatment like a neoadjuvant approach, or should it be surgery followed by the systemic approach?
I think the hormonal profile will help answering the query whether what's a hormone positive disease, HER2 positive disease, and oligometastatic disease. If it's a bone only mets, then definitely we can go ahead with surgery. But if it's a visceral mets, I think a trial of chemotherapy to show whether disease is stable or responsive, and then only I think we go for surgery.
Okay.
Maybe
So,
you can make us wiser with your experience here.
right. Again, the volume of disease and all that would be taken into consideration. So there is a question by Dr. Ulfat Aravani. If patient has progressed on trastuzumab, can trastuzumab be used in subsequent lines? Dr. Jyoti?
Yes, as I mentioned earlier, it all depends as to how well the patient did on trastuzumab and for how long the patient did well and how was the tolerance to the drug. So all these factors need to be taken into consideration before making such a decision. Yes, it can definitely continue to be an option, especially after a treatment-free interval. So suppose a patient got trastuzumab-based treatment as the first line, went on to receive, say, lapatinib-based combination in the second line or something else, then one is always, free to choose and come back to trastuzumab-based treatment subsequently if the trastuzumab-free interval has been significant. And
Very
if it worked in the first line, yes.
Very well. I think if we go back to the Teresa trial, the randomization was the TDM1 versus the treatment of physician's choice. And a lot of them received only chemotherapy. Some of them continued to have the HER-directed trastuzumab as well. And as you saw from the trastuzumab DirectScan data, ladies have received, very surprising, more than 20 lines of therapies actually. So this is something. So they would have gone back to trastuzumab back and forth many times during this journey of the patient's treatment.
Right.
So there is a question again about tucatinib plus pertuzumab. Dr. Jyoti, any data on that? And also, which AI is best in the HER2 positive disease? And let me share with everyone on the program that we have more than 160 people live at this time on the program, and then more than 30 people from overseas sites also logged in. Thank you so much. So Dr. Jyoti, tucatinib plus pertuzumab, and which AI would be best for the combination with?
So coming to tucatinib with pertuzumab combination, I'm not aware. In the HER2 climb, tucatinib was combined with trastuzumab-based combination. However, it does make sense to use it with dual HER2 blockade and study the efficacy. So trastuzumab, pertuzumab, and tucatinib would make sense, and I'm sure study must be ongoing. Second question was, sir, if you could repeat the second part.
One second. The second question is that which AI is the best in combination with trastuzumab?
So I would say all three, namely anastrozole, letrozole, or exemestane, all should be equivalent. As we have seen otherwise also for treatment of hormone receptor positive metastatic breast cancer. So one is free to choose. The quality of life is a little variable. With letrozole, it's said to be, causing less of arthralgias and all, but efficacy wise, there's hardly anything to choose between them.
So if I may, continue from where Dr. Jyoti's left, that go back to the tandem trial data. We were part of the publication, and tandem trial was trastuzumab and anastrozole. We had a patient in the later line who continued to respond up to 33 months in the later lines. So as already pointed out, all three are equivalent. Look at your patient and what has been the experience from the previous lines and the treatment-free interval. You could choose any one of them. It's a wide open choice. There are no questions at the moment, but I have a question for Dr. Neera. Dr. Neera, there are, now close to a dozen biosimilars and maybe more if my count is not correct. So a clinician is always lost. It's not a question of who's the best and who's the worst. There can't be a best and worst. There could be an equivalence again amongst the biosimilars. So how does a clinician decide in the clinic?
So it's a great question, sir, and that's the dilemma. I think in today's world, each oncologist must be having it, because on prima facie, it looks like if regulatory authorities have approved, then we can use whichever is available in the market. However, and the time constraints with busy practitioners is that they're just really not able to go into the detail that what kind of evidence has been generated, whether the proper comparative statistically defined sample size trial has been done or not done, whether the long-term follow-up is done or not, whether the characterization data is available, whether pharmacokinetic data is available. And there are a lot of published literature, sir, which talks about the formulary selection of these biosimilars. And they have clearly defined that these are the criteria looking at which the biosimilar selection should be made. So I understand that amongst so many biosimilars, how do we choose it? But we need to take a deeper dive into it, look at the data which has been generated and how the molecule has developed right from the identification of the clone till the final product, which is available in the market, whether stability studies have been done, whether fingerprinting like tests have been done, whether sensitive assays have been used, whether orthogonal methods have been tested or not. So, and the pivotal data, because you know that in India, we are fine with 100 patients data on experimental arm, but there is an ask that more than 200 patients should be tested in the post-marketing. Once the authorization is granted, after that 200 plus patients should be tested and given the data. But do we really have that data published, or is it really existing? We should question that and look into the outcome analysis, that what is the outcome of these biosimilars, and then make a conscious decision that this is the right biosimilar for our patient, that gives the confidence, yes, it is giving the outcomes as desired, as close to as innovator being the original biosimilar. Sir, you are on mute, sir.
Thank you, Dr. Neera. Very well summarized. I think the dilemma would continue to exist because the clinicians don't have the time and the access to all that, and obviously, once the regulator has approved a product, the clinician has no locus standi to question what the regulator has done. Very well.
Sir, I have two questions, if you kindly allow me to ask.
Please.
Yeah, thank you, sir. So, sir, I want to ask you first question about pertuzumab. How many patients, what percentage of the patients must be receiving, as this is a standard of care now, the pertu plus trastu combination? What percentage of the patients are receiving this combination currently in India, if we talk about?
So, Dr. Jyoti, would you like to offer your comments on that?
So I could share in my own experience as to what we are able to do. I would say almost 20% of our patients are able to say yes to the dual HER2 blockade treatment in the first line treatment of HER2 positive breast cancer. And if the patient is able to, if the patient has, say, CGHS, ECHS coverage, wherein it is covered, then many more. But with the patient assistance program, which is currently ongoing, 20% of the patients are definitely getting it as the first-line treatment. This is rough
Thanks.
estimate. I haven't done any analysis.
Difficult to put a percentage to that, and because the drug is expensive, and the opportunities to treat the patients are only in the neoadjuvant node positive and in the metastatic setting. And when one has to realize that the metastatic setting doesn't define how long do you use this drug, and it's a difficult proposition for the physician as well in the clinic. So I think there are challenges, yes.
Yeah, true, sir. So, sir, looking at the affinity data and the not that encouraging outcomes, do you really think role of pertuzumab there in adjuvant setting?
The number of patients treated on that type of protocol, it's a single digit. I still remember the number of patients treated by me, because in our setting, if somebody is node positive, and we make a very conscious effort to prove or disprove the node, and if node positive, then there is no question of an affinity type of no question of upfront surgery. Then we are all treating them with neoadjuvant, because then your story finishes with the 6 doses of pertuzumab. And if they are node negative or small tumors, then obviously they go for surgery, and then depending upon what happens. And affinity would kick in if the node is positive. It's a surprise that postoperatively you got a node positive.
Right, sir. So my last question relating to neoadjuvant settings, sir, when we are talking about PER2 plus TRAS2, looking at phase 2 data from PHESGO and subcutaneous formulations, how do you see the role of subcutaneous combination preparations in current situation and in future vis-a-vis use of TRAS2 plus PER2?
So it is already arrived. It is a reality. We have already started shifting our patients from the intravenous to the subcutaneous. There is no reason to continue with the intravenous. Wherever possible, it's a subcutaneous now.
So do you really think that there could be some challenges right now on future, or as the time goes and if affordability allows, that is going to replace the TRAS2 plus PER2?
Absolutely. If you give me the drug at the same cost, why should a lady spend several hours in the treatment facility? They could get it subcutaneous.
What about immunogenicity? Did you check any time?
So again, I'm not the guy who would be questioning all that. Back to the same observation that somebody's looked at the data, somebody's given an approval, somebody's following it up, and then if the regulator is fine enough with that, the clinician has no locus standi, number one, and no way of doing it. Where do I go to do the immunogenicity studies? Who funds that? And then what's the end point? Nobody would allow me to do the immunogenicity studies in my institution, nowhere, without a patient consent and ethics approval.
Any indirect evidence of maybe safety concerns like that? I understand absolutely that in clinical practice it may not be a workable option, but otherwise.
No, I don't think so. I don't think that a clinician has any sort of information or any data to get into those areas.
Great, sir. Any other questions? Dr. Viraj, you are there. I think, thank you, Dr. Bhatt, sir, and thank you, Dr. Jyoti. No more questions from my side.
Thank you so much. And I don't see any questions in the chat box or in the question answer section. So thanks once again to everyone, Biocon, all the presenters, Dr. Neera, and last but not the least, Rajesh and your team, and Neera, very enthusiastic. My thanks to Priyanshi, and back to you, Priyanshi, to close the session. Thank you so much.
Thank you so much to all the doctors for presenting and attending such a knowledgeable webinar. With this, I would personally like to thank to each and every doctor. Also, thank you, Ved sir, for giving me the opportunity to moderate your webinar. And thank you. With this, I would like to invite someone from Biocon Biologics to give vote of thanks. Over to you, Neera ma'am, or someone from Biocon. Thank you.
Puneet, would you take the honor?
Thank you, Dr. Neera, for, thank you, Beth sir. Thank you, Dr. Jyoti, Dr. Samir sir, for taking us through with a very, very important, subject line, which has been touched upon today. We have a lot of, international faculties with us, delegates with us, as well as our Indian delegates who must be benefited out of this program. So once again, thank you very much for giving us opportunity to be part of you all for this scientific CMS. Thank you, sir.
Thank you. Bye-bye.
Thank you, sir.
Thank you all.
Dr.
Thank
Jyoti.
you.
Thank you all. Good night.